I'll be in order. Go and do roll call. Kim,
Here.
Heather,
Here.
Marlene,
Here.
Joe. Not here. Cindy. Not here. Micah. Not here. And myself, Jared, is here. Approval of the agenda. Would before you go and state your name when you. Thanks. Okay, Joe is just here. Do I have an approval for the agenda?
This is Heather. I move to approve the agenda. Yeah, my second.
All in favor?
Aye.
Approval of board minutes from February 22nd, 2024, board minute meeting.
I move we approve of the minutes as submitted.
I will second.
All in favor?
Aye.
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 Thank you. Do we have any visitors' comments? Seeing none. Board member comments? Yes, Marlene?
I wanted to mention that there was a survey of the long-term care earlier this month with federal and state surveyors here. And the surveyors said that they were witnessing exemplary care being given at the long-term care facility. So I think that needs to be noted, and the entire long-term care staff complimented, and all the other staff that contribute to long-term care.
Thank you. I'd just like to comment on Phil's accomplishment of coming in third on his bike trek of the Iditarod Trail. That is an accomplishment that I can't comprehend.
Just glad to be back. So,
Any other board member comments?
Did you recruit anybody else to come down from Nome?
I was trying the whole way. Yeah.
Committee comments? No, sorry, committee reports. Resource committee, we met earlier this week. We're still doing okay there as far as finances go. We did get an influx of money come in, and we made the decision to move $1 million into what would be the
It's a reserve into.
Yeah, into the reserve.
Replenish the reserve that we were
And-
using, yeah.
that move will almost get us halfway to what we had to pull out of it over the last year or so, 2 years. So that was the biggest thing that came out of that meeting. LTC,
The long-term care meeting was on the 20th of March. And went over reports and discussed this survey visit, and that's it.
thank you, Molly. CAH,
Yeah, this is Joe Stratman. I attended the Critical Access Hospital Committee meeting also on March 20th. Just a couple highlights. We went over the active policy list. Some of I guess the next step is to clean up the policy list rather and bring it to the policy committee to review, and then eventually it'll come to the board here for our review. We reviewed the action item list. Some of the items were closed. In other words, they'd been addressed since the last meeting and some remained open. Sort of the highlight of the facility report was a sewer line replacement project. The clinic report went over the hypertension quality project and access to care, tracking physician availability. In the skilled nursing report, we heard that the census is down in swing bed over the last month. Infection control, Jennifer mentioned they're focusing on long-term care infection control. Radiology report went over some lung cancer screening metrics, and in the lab, Violet reported that they're looking at the various reasons for canceled blood tests and looking at urine sample test quality in nutrition. Jeanette mentioned they're updating the HACCP logs in the kitchen. And for wellness, there's ongoing work on the tobacco prevention program. And they discussed quantifying the health fair metrics in the future. That's all I got.
You, Joe? Reports, information technology. Did anyone have any questions regarding that report?
Yeah, I had one question about that report. Is Jill, is Jill here?
She's not on,
Oh,
I
okay.
can,
Oh, okay. Well, it's not a big deal. I could follow up with her later. It was just a question about the this DAX, the ambient physician documentation software. I just was curious to know a little bit more about that, but I can follow up with her later.
we have Dr. Hess in the room. She could actually comment on it because she's the one using it. It's our AI version for documentation system that was obtained. Do you want to
Okay.
comment
Yeah,
on
I
that,
guess-
Dr. Hess?
Is this DAX, is it simply a tool like to like improve dictation that physicians do, or is there more to it than that? Is it coding and that tied into it, or?
Coding's not tied into it, but it does, they are trained.
Dr. Hess, can you speak into the
Sorry.
mic? Sorry.
Coding's not directly tied into it, but the AI scribe DAX system is designed to pick up things that we're saying that they know are keywords for coding. So they found that those visits actually can tend to code a little bit higher because they are putting appropriate billing points in. And that's what we've heard in terms of some feedback from our coding department, that some of those notes are actually better in terms of being able to prove appropriate level of reimbursement. So, and then back to your kind of initial point, it's a scribe. It's basically an AI plus human scribe that are listening to those recordings and generating a note out of that. And then the physician or provider goes behind that and reads it and edits it as appropriate and signs it. So it does make the actual documentation process for the provider a lot faster and actually more accurate and complete.
Okay, yeah, thanks, Dr. Hess.
Any other questions regarding that report? Thank you, Joe, for that report. Materials management. Any questions on that report? The only question I have, this is Jared. One of the last things in a report is a challenge with high shipping costs continue. And is there any way to work with that? I mean, is there any other way to bring stuff into town that would be cheaper?
Yeah, and Melva does a really good job troubleshooting those kinds of problems. I think that she's not here, but she can definitely, I know, we talk with her quite a bit about that. They try to work with Bartlett sometimes on real high dollar amounts, trying different ways to bring in a shipment if it's something that costs or is a significant amount. So they're constantly challenged with that. I know they think outside the box and trying to improve that situation, but it's a significant challenge, and it's just sometimes just no way to avoid it. But we work with they work with other hospitals to either group the shipment, try different kinds of ways to ship it. Sometimes when they go on, they automatically select something that ends up being a lot higher, and then they have to go and talk to the vendor, and they're doing that all day long. So trying very hard to keep the cost down.
Thank you, Phil.
Yeah.
Any other questions regarding that report? Thank you, Melba, for that report. Moving on to medical records. Any questions regarding Kim's report? Done. Thank you, Kim, for that report. Nursing? Any questions on Jennifer's report?
This is Joe. No questions, just a comment. I think the plan to offer the CNA class to the high school next year is a good one. And hopefully that'll bear some fruit, getting some more CNAs in the hospital.
Any other comments on that report? Jennifer, for that report? New facility.
So for this, I'll probably like to introduce Mike Cruz on this one. So as I discussed with the board at the last meeting, we're put an RFP out for a project manager. As the project becomes more active and real as far as complexity, Jay Farmwald, who has been working with us for a number of years, has asked to transition to a firm to take on that burden as the project grows. And so we did that, and we had a selection committee. We had an RFP that was sent out, and we are pleased to report we selected Arcadis, and we have Mike Cruz that is online, and he'll be working with our team as the PM. Mike, do you want to introduce yourself? And we have worked together in the past, so I know Mike pretty well.
Yeah, hi, good evening. Thanks for having me. Yeah, so like Phil mentioned, I'm Mike Cruz. I'm a area operations leader up here in Anchorage for Arcadis. And yeah, Phil and I go all the way back to the Nome Hospital activation back in 2013 and worked together at Norton Sound Health. I actually continued to work there up until 2018, then moved down here and continued to support Norton Sound. And now I am managing our Arcadis division here. And we're really looking forward to this project. Looking forward to getting back to Petersburg. I've been there a couple times and always enjoyed my time there. I've also got online, I think, Justin Wetzel. Are you still on? Yeah, so go ahead,
Hi,
Justin.
everybody.
You want to introduce yourself real quick?
Yeah, for sure. My name is Justin Wetzel, and I work with Arcadis I have been for the last couple of years, and kind of excited to get started on this project, and looking forward to meeting everyone and working with everybody. Just a little bit of a background for me. I've been in construction for over 25 years in the commercial industry, and primarily, all over Alaska, really. But yeah, looking forward to getting started.
Yeah, so some more history there. Justin and I actually worked in Nome for Norton Sound Health Corporation, building several buildings, including an MRI addition, a wellness and training center, and worked really well together. And then when we kind of both left Nome, we ended up working together now at Arcadis. And then also Jay Farmwald is, I have an even longer history with Jay. Jay recruited me to go to Nome, talked me into moving to Nome and building the hospital with him. And then I ended up staying in Nome for a very long time. And then 10 years later, he recruited me to come help at Arcadis. So I owe a lot to Jay and have a good working relationship with him, and looking forward to working with this team. I think it's going to be great. Also with Petersburg, Justin and I worked with Petersburg in Nome. I've got a good working relationship with Roy and his team. So it's a lot of good synergies about to happen.
All right, thanks. Maybe for the purpose of the meeting, Jay, you would want to handle the report?
Sure. Thank you very much. Before I ask if there are any questions on the report that I submitted to the board, let me just say that, yes, the transition couldn't be going into better hands from my perspective. Mike's, a true owner's rep, and early in his career worked for a general contractor. Justin has many years working for a general contractor, so he knows the ins and outs from that side. So it's a great combination. Oh, there I am. So, I am very sorry to transition out of my primary role. As I told the board in executive session, you know, as long as possible, I'll continue to support. I do want to remind everybody that this was the plan all along when Phil called me 4 years ago to get this thing started. The agreement was when it went to actual hard construction that there would need to be a transition. So this is the implementation of that. So I provided a one-page summary. Mr. Chair, would you prefer that I say a few things or just open it up for questions?
Go ahead and say.
Okay, real briefly, and we've got Roy Roundtree from Bettesworth, the architect, on the panel as well, and Ben Kuhn from Dawson. So if there are any questions as we go through this, or either the design team or the general contractor, feel free to direct your questions to them. Site work, happy to report that Rock and Road is now using the borough source, and that's reducing truck traffic because the times are shorter. It's also reducing cost. They anticipate that site work will be complete for both the wellness center and the main hospital building itself by mid-May. And the goal there, of course, is to take a bunch of pictures and declare the site for the main hospital shovel ready. Specifically with respect to the wellness center, the borough on March 4th approved a $3.3 million notice to proceed so that we could get long lead items ordered, including things like steel, in order to maintain overall schedule. Dawson is planning to start foundation work in April and steel erection in July. The design proceeds as we speak. 65% design documents were published last Friday. That's what Dawson is using to generate a guaranteed max price for the work project. Over 140 sheets of drawings. Phil distributed those to his staff today for review, plus a bunch of specifications and narrative. So it's not an insignificant pile of paper. What else to say? Actual final design, 100% design documents that will go in for full permitting are due in early June. The overall goal is to have the roof on the work building by September and then get it in the dry. And then work continuing inside throughout the winter and completion summer of 25. With respect to the main hospital building, which we're now starting to talk about it more in terms of the main hospital and the long-term care facility or building. I think it's really important to drive the point home to funders in particular that this is more than just a hospital. You know, that word means certain things to certain people, but you know, almost half the building is long-term care. So I think we all ought to get in the habit of referring to it as a hospital and a long-term care facility. The $37 million request to the state is still pending for the main building. And last week we submitted an application to Senator Murkowski for her FY25 cycle. And if it hasn't already gone in, it will. I'm pretty sure it's going in the next day or two. Sister request to Representative Peltola. And if that state request and the two requests to Murkowski and Peltola bear fruit, then you would essentially be there. We're also submitting in a couple of weeks a $2 million request to the Denali Commission out of their infrastructure bucket to put some icing on the cake. And I don't know, Phil, do you want to say anything about the funding requests and community outreach to legislators as we move forward into this? I mean, April and May will be critical months for seeing how much money is to be harvested for the main building.
Yeah. So I mentioned this on the KFSK Live as well, that the community to outreach to their legislator is really important for us both to state. We want to make sure that Senator Stedman and Representative Himschoot receive letters and phone calls and emails supporting the project. It's really important to make sure that the community is in support of that. We met with a team a few months ago to Juneau, where we flew up and provided a briefing to Senator Stedman, and then I went to the legislative fly-in a few weeks ago in late February to do the same thing and follow up with Senator Hoffman and Senator Olson, who sit on the Senate Finance Committee. So it's really important that the legislators hear from the community, and it's not going to be something that is just heard from the hospital or even the borough or the board, but the community is, it's really important to make sure that there's some advocacy there. And also on the federal side with Senator Murkowski and Representative Peltola to show the support from the community. Those things mean more than me speaking to them directly. So thank you, Jay. Well, we have that information on our website. It does not have to be a real formal letter. It can be an email, it can be a phone call, it can be something pretty brief. So don't feel intimidated to do that outreach.
One last thing I'd like to say is, again, it's been an honor working on the project in my initial role. And I want to reassure the board that I will do everything possible to make sure the transition is smooth and comprehensive. And would happy to field any questions on the report at this time.
Questions for Jay? Thank you, Jay, for your time on this project with us. It's been a pleasure to have you on board, and it's been very helpful for us to move forward as far as we have with you at the wheel there. So I do thank you for that.
Thank you.
So moving on to quality and IP from Stephanie. Are there any questions on that report? None. Thank you, Stephanie. Executive report. Or wait, yeah, executive report.
Okay, so it's mine. Any comments? I'll just do some highlights as I normally do and add a few things. As we're always in flux since I've written the report, I have a few updates as well.
I want to say that the health fair that PMC put on was very impressive. I think we had more vendors than we've ever had before, and they came with quality information, and several of them put on workshops for the community before and after the health fair. So that was very beneficial, and I hope that the people who came got a lot out of it.
Yeah, I echo that. The whole wellness group, there was a lot of people involved, and I don't want to risk not giving credit, but Julie Walker and the wellness group lab, even before leading up to the wellness, the health fair, we had labs drawn. I think the number was around 500, right? Was that right, Dr. S? Yeah, so that's a tremendous percentage of the population of Petersburg getting their labs done, and then some follow-up, and really fantastic health fair, and multi-day, and even the wilderness training and providing that to the community and all the vendors. Just excellent. Yeah, I can't say enough good things about it. It was really well received, I felt too. Thank you.
Bill, Marlene, any questions?
I have a few more
Yeah, go
things.
ahead,
So a couple of things that were not on there that I just want to acknowledge is that Peace Health was here today, or is here today, actually spending a night. The CEO flew in with one of the orthopedic surgeons and trying to build out some opportunities for specialties. That was exciting. That's fresh in the works right now. So working with some specialties to provide improved care, or access to care, I should say, in Petersburg is something that we've been, as one of the goals for the past year, and developing those relationships. And we're very excited to have them here and build out some opportunities as well, in addition to the other specialties we've been working on. So, you know, we've had scopes, and I'm glad Michelle's here going to give a presentation on the importance of colorectal screening. So thank you for providing that information. I think it's very valuable. And so for us as a hospital, providing the opportunity for that prevention through scopes is very, very important. And we are working with Search on that. So I'm actually very excited to work with a lot of the different agencies. I feel like that's a value added as a community hospital, selecting specialists that really fit into our community, that work well, and having diverse opportunities is very important. So let's see what else. Employee forum. So every year it's to make sure that we have it's equivalent of I guess a fancy way of saying an all staff meeting. And we want to make sure that we have that. I'm looking at May 9th as a possible date for that. So just something to mark on your calendars for the board. It's always good to have a board presence there for the employee forum. And we'll have 2 opportunities to present to the staff. And we're also going to provide an employee survey, just a check-in survey on how do you like working at PMC, just sort of a more of a wellness check. It's going to be anonymous, so it'll be something we'll be providing to staff to make sure that we get some information. So we'll have that probably at the time on May 9th for staff to complete. Let's see, anything else I'm missing on that, Karen?
Times.
10 and 2. I think we'll do 10 and 2. That seems like the one that we did 3 sessions last year, but really the last session was not attended. So we're going to stick to 10 and 2 for that. And we'll get more, once we firm that up, we'll get that out to you with an agenda. We had PMC Live today. I want to thank Julie Walker, Kelly's wife, Sonia Paul, for talking about the new 3D mammogram that we have here, which I think she does a really good job speaking on. And additionally, want to thank the borough for providing that ARPA funding to help support and pay for a portion of that mammogram. So that was that's something that's well used, and Sonia's very, very happy with the accuracy and the results of that. New facility we covered. Finances, Jason will cover that again. A big highlight for me, and a little bit of a sigh of relief is replenishing the reserves that we had to dip into during COVID or coming out of COVID, which was a big challenge for the organization. So to me, it's a major landmark and improvement. So great job with our teams on getting that together and making that happen. Let's see. I think that's about it for highlights for me. Are there any questions or comments?
Go ahead, Joe.
Phil, this is Joe. In your report, you mentioned there was a request for proposals due on March 12th for the project manager, and that the selection committee was going to meet in March. So we to assume that Mr. Cruz was chosen by the committee?
Yes, that's correct.
Okay.
Yep. Yeah, that was the Arcadis was the group, and Mike Cruz is part of Arcadis along with Justin.
Okay. All right. Thank you.
Any other questions for Phil? Thank you, Phil, for that report. Financials.
Evening, everybody. Let me pull up the financial statement on the screen here. Give me 1 second. Just a few highlights. I always like going over the statistics first, just to help the board be aware. The patient volumes on the inpatient swing bed are down a little bit. They've been busier, quite busy earlier this winter. but they're down. Year to date, we're seeing that total patient days on the acute care unit, 513 as compared to 558. What does this mean for our cost report? Because we're less than last year, it means in general that Medicare owes us some money versus us having to repay them. Certainly, people become ill. We like to see those numbers come back up. Days in long-term care, we have been fairly strong through most of the year. The census is down in the month of February, but you can see year to date, 3,366 days as compared to the prior year, 2,915. Cost report works differently for Medicaid than it does Medicare. There's not necessarily a settlement, so it's always good. You know, our rates went up 26-30% this past year, and it's good to see that the volumes are up over 2 years ago. Emergency department visits, 54 for the month. The year to date, 603 as compared to 518. You know, the outpatient areas, you know, some departments are up, some are down a little bit, but in general, running similar to the prior year. Why is that important? Once again, looking at our cost report, I'm always trying to keep an eye on that. We'll have a detailed report next month with regards to where we sit. We were waiting on the settlement of the cost report to come through and what we call an updated interim rate letter to be able to complete that. Jumping down here to the financial performance. So our gross revenues, partly due to slower volumes on the inpatient unit. Some of it also, we haven't quite increased the charges as much as we had anticipated in the budget, but our gross revenues are down from what we had anticipated in the budget. Contractual adjustments are better than we had anticipated, meaning they're less than we anticipated because we got the rate improvements from both Medicare and Medicaid. And so that's going in our favor. So our net revenues, as you can see for the month of February, are 109 off of budget. So 1,887,000 was our net patient revenues estimate against a budget of 1,996,000. On the other hand, our total expenses are down 151,000. We've been doing a very good job with some expense management with regards to our budget. And so our total expenses are 1,812,000 as compared to 1,963,000. You know, once again, looking at the cost report, what does that mean? Well, if our costs are down, then in a lot of cases, that would mean we would have to reimburse Medicare. But we're finding that majority of our expense has to deal with physicians. We had more physicians on staff last year. That has declined this year as some transitions have gone through. So physician expense doesn't flow through the cost report. It's the other things. And so that reduction in expense doesn't all impact the cost report. There are some savings in some other areas, contract labor, purchase services, and that has an impact. But in general, we are seeing year to date that our expense base is about 2% less than it was, almost 3% less than it was from the prior year. Volumes are close, if not down, but our inpatient unit, the volumes are down. So I don't anticipate us owing Medicare any money. Once again, I'll have an updated report. But as far as the operating bottom line, you can see we have a $75,000 positive bottom line for the month of February. Year to date, $730,000. And of course, with the revenues coming in from the capital grants, the treasury, and that on the construction project, a positive swing on the income on the investments, doing very well on the change in net position line. So overall doing well, as was indicated. We received 2 payments from Medicare on the cost report settlement. One was $664,000, as was anticipated. They didn't object to the cost report as submitted. And then there was a catch-up payment for the year to date from July through January, February of another almost $400,000. So we received $1 million. We were sitting at a cash balance at the time last week at about $700,000 $750,000. Our accounts payable balances are for the most part caught up. So we're feeling good about that. And so we went ahead and transferred that $1 million into our short-term reserve account, not our long-term reserve account. I would like to see if, as we continue to work on the reduction in accounts receivable and some other profitability in the organization, maybe in the coming months, we can get some more monies in there and get built back up. Just a reminder to the board that prior to COVID, we were sitting at about $5 million between the two different reserve accounts. There was 2.5 in one and 2.5 in the other. Our investments have grown, so we're sitting in 3 million in our long-term reserves right now, and 1 million in our short-term with this transfer. Great to see another $1.5 million come in, get back up to that 5 million mark. We've got a couple big projects we're working on. First is the budget. Joel is taking a strong lead there and meeting with department managers and providing them with information. Working on some insurance renewals. But the big one is putting together a process this year for transitioning our accounts receivable, trying to bring some of that in-house and move the other services to a different vendor or to in-house. We're working through that. It's going to take a little bit of time to figure out how to come up with the expertise we need for insurance billing and collections. But we haven't achieved our goals, and it's time to make some additional improvements there. So, any questions from the financial statements?
Jason? Thank you, Jason.
You're welcome.
Any old business, so new business, presentation, rising colorectal cancer awareness by Michelle Parker. Let's beat the odds.
Is that speaker on, Karen? Yeah, if you don't mind. Yeah.
Hi, I'm Michelle Parker, and I'm the chairperson of Beat the Odds, and I'm here representing Beat the Odds. Next slide, please. So I had the opportunity last November to attend the National Colorectal Cancer Roundtable. And at that roundtable, I learned that they're guided by an 80% strategy, but they're striving to reduce colorectal cancer by getting 80%, you can go to the next slide, screened in every community. And they have 1,800 organizations working towards that goal right now. Next slide. So there I learned Alaska Natives have the highest rates and mortality of colorectal cancer in the world, not just the United States, but the world. So 91.3 cases for Alaska Natives compared to 35.5 per 100,000. I mean, that's a striking difference. Thus, it's a major health problem for Alaska Natives. Next slide. Colorectal cancer is the second leading cancer among Alaska Natives, but it's also a highly preventable cancer. Colonoscopies can detect polyps before they turn into cancer, and they can be easily removed. 1 in 24 is the average rate of anyone obtaining colorectal cancer, and it's 1 in 13 for Alaska Natives. So this graph shows a lot of times they combine Alaska Natives with American Indians, and the difference isn't as striking. But here it's separate, and you can see Alaska Natives have more cases, almost double that of American Indians, and above all the other groups. Next slide. There you are. And the same's true for the mortality. Next slide. This shows the statistics of screening throughout the United States. Alaska, as a state, was at 63% in 2023. Next slide. And then this one is current. It shows the number has gone down 55% for the state of Alaska as a whole. That's probably due to COVID. And then for Southeast Alaska, you can see our number is 53%. And this data is provided by the Alaska Behavior Risk Factor Surveillance System. Next slide. So this table shows that, that's wrong there, 44% of cases are in people younger than 65 years. And that's up 27% from 1995. This year, there's estimated 350 new cases and 110 deaths in Alaska will occur in 2024. Next slide. And then although overall cancer mortality, colorectal cancer mortality rates are decreasing, you can see in the 20 to 49-year-olds, it's constantly going up. It's at a 1 to 2% each year. Next slide. So that's very alarming. And I know there's been more information shared on it, which is great, especially this month. March is Colorectal Awareness Month. But colorectal cancer, it's shifting to a diagnosis at a younger age. It's occurring more in the left side of your colon, and it's happening at a more advanced stage. But screening can save lives. When it's diagnosed at the localized stage, you have a 91% 5-year survival rate. But only 1 in 3 cases are diagnosed at that stage. When it's diagnosed at an advanced stage, like my colorectal cancer was, the survival rate is only 14. And because it's occurring on your left side of your colon, near your rectum, at a more advanced stage, a lot of the survivors will have LARS, lower anterior resection syndrome, that they'll have to deal with for a longer period of their life. Next slide. So it's really important to use the right channels and to use the right messages to deliver those colorectal awareness reasons to get screened. And the top 4 ways we learned from the roundtable is through a doctor. 60% of people like to hear it directly from their doctor. A website, 35%. Email, 26%, and then a patient portal, 24%. Next slide. At the roundtable, I also learned that younger people want to be told about colorectal cancer screening. They want to get screened on time. They want to hear about it. So I can't overstate the importance of having your doctor talk to young people and ask if they have a family history, see if they're Alaska Native. They should be screened at 40 instead of 45 years, and talk to them about any symptoms. Next slide. So we would love to partner with PMC. We'd love to have PMC's help calculating the pre-screening rates so we can develop a baseline of how many people are screened in Petersburg right now. And then we can provide analytical aggregated medical data on the post-screening rates after we go through this campaign to bring awareness and increase screening to Petersburg. So we love the opportunity to be at the public health fair. We had a table there. We've had ads in the newspaper, PSAs this March for colorectal awareness. We're also partnering with the Alaska Native Tribal Health Consortium, the American Native Indian Association, and we're going to try to, with PIA. Here's some information, some posters and stuff. We'd love PIA's help to tailor the messages to our Alaska Natives, to have a champion, to help with patient incentives, have a raffle, give out Chamber of Commerce gift cards. and to provide transportation to and from colonoscopies, because those are some of the things that people don't have them because of. They don't want to ask a friend for a ride. They just want to be anonymous. And we'd love PMC to help with education, patient reminders, postcards, phone calls. Maybe the patient navigator could help. We'd love a clinical champion. Dr. Heyer has been our champion for Beat the Odds, but she's gone right now. We have template letters, a sample script. We have lots of information. There's a lead time messaging book, just hot off the press. So we have lots of resources to use. And I think it's great that at the health fair, you were able to get fit testing. That's awesome. It'd be good to get the word out about DNA fit testing also. I know we're not able to send the test on time. It has to get to Madison, Wisconsin in 72 hours, but people who are going on vacation, perhaps in the lower 48, could take the kit with them, or they could have it sent down there, and then they could do that simple DNA testing. Next slide. So I feel prioritizing colorectal cancer isn't a choice, but it's a need, and we would love PMC's help to make that happen. Next slide. Any questions? And thank you for the opportunity to present today.
During this study and where they got the information, did they come up with a why there's such a difference?
They don't know why yet, and why they think it's younger people every year is the processed food, but they haven't clearly stated that yet. But because I got my colorectal cancer at age 42, and I don't have any genetic genes, my daughters will be tested in their 20s. It's a long-term growing cancer, but you can stop it easily. And colonoscopy is the gold standard, although any test you are going to take is better than no test at all.
Are there, just another question I have, are there any issues with getting insurance coverage at these younger age groups for this testing?
There may be. If you have a family history, though, I think you could argue with your insurance. I mean, it's recommended 40 and younger if you have a family history. Usually they say 10 years younger than your family member, but I talk to doctors, and because it is such a slow growing, my daughters will have to have it in their late 20s. You know, we're not going to wait.
Sounds good. Thank you very much for
Sure.
your present too. So thank you, Michelle. Yeah.
Thank you. Okay, moving on, the next meeting. Twenty-fifth or 18th.
25th.
That? 18th and 25th? 18th and 25th?
I think either's fine for me. Oh, no, no, no. I can't do it the 18th.
Buddy,
Do it on the 25th.
which day would we normally have it on, the 18th or the 25th? 25th? We're probably better off sticking with that date, the 25th, and hoping we have a quorum.
I can come for the beginning. It's but I can come for the beginning. Yeah.
Plan on the 25th at this point, I guess. Hope we have a quorum, because it doesn't sound like we'll have it for the 18th either. Do I have a motion for the board to enter into executive session to consider medical staff appointments and reappointments?
I so moved.
I second that.
All in favor?
Aye. Aye.